Good day, my name is Kenneth Rosenfield, and I'm here with Drs. Gloria Salazar and Bill Gray. We're going to talk today about radiation protection in the modern fluoroscopy suite and the evolution and the changes that are happening very actively in this area. Scatter protection is really becoming a mandate now in labs. The time has really come for a change. I think the entire interventional community is recognizing that, in particular cardiology. And I want to hear about radiology and what you all think. You guys are all about radiation, and so you know more about it than we do. And I'd love to hear your opinions about this, Gloria. Mm-hmm. There are lots of challenges as we try to improve our scatter protection. We all recognize the incredible impact it has on our occupational health. I think there's a sense of awareness now that wasn't there before, and a sense of urgency to do something about it at our hospital systems or in our practices, and trying to convince our hospital systems to change. So let's focus on what really matters when we're thinking about protecting our teams and ourselves. Well, as we all know, there's a lot of attention focused on trying to develop advanced ERPDs to try to protect us all against scatter radiation and enable us to lighten our loads and wear lighter lead or no lead. I mean, there's Rampart, there's Protego, there's Eggnest, there's zero gravity, and there's radiation. And then there's the new kid on the block, which we are all going to talk about today, which is Salus Scientific and their AeroShield, as well as their G-Lift and their sort of what I call the 360-degree wraparound protection. They're embracing us with their technology, trying to protect everybody in the room and prevent longer-term consequences of having to work in this fairly tough environment. So what do you all think is really the way we should be going? What represents meaningful protection now? And maybe Gloria, you could talk a little bit about this in your environment in the radiology space.
Yes, no, thank you, Kenny. I think you already mentioned radiologists or interventional radiologists have to learn about radiation. We have a physics sort of course in our training and specific to radiation protection as well. So we learn a lot about it. But unfortunately, knowledge is not enough. What I observe in the last 20 years that I've been practicing is that just the physicians don't really practice what they learn, and also they don't understand how to operationalize in an angio suit, how to be more protective of themselves and of the team. And this is particularly meaningful in our environment because we are a teamwork environment. We have anesthesiologists as well. So it's really important that we keep in mind that everybody in the room should be protected. But for us in particular in interventional radiology, even with all this knowledge we have, we still have misunderstanding, myths about radiation that actually prevents medical students to go into the field. So there's still fear of radiation. Yeah. So that becomes even more important, that we were not able to even dissolve this sort of like myth or this lack of knowledge of how to protect yourself.
Why do you think that's the case? It's interesting to me. I'm the same way. I don't, only recently have I sort of say, okay, take 2 steps back or put out those cones, the hard cones on the image. Why do you think that doesn't happen?
It's a great question, and I think, let me just talk about something I think is going to be a major benefit from all the systems you looked at and others that are to come, which is that it's raising the awareness of radiation protection, okay? If we just use what we have in the lab today, we would have materially more radiation protection than we have, and we can improve on that with the systems and others that we're talking about. But the problem is that the staff don't always even cover the shield. Okay? The fellows are so intent on learning and doing the case, and they're so excited doing it, that they don't pay attention. I can't tell you how many times I've taken the shield and shoved it in front of the fellow and said, please use this, you know, if no other reason than for me, who's standing next to you. And I think the other problem is that those are some of the issues around adoption and integration in our workflow. And I think we're going to have to pay attention to that. We're going to have to, no matter what next system we end up adopting, we're going to have to take a minute to put the system in place so that it can protect us and the people in the room. The other thing that's challenging right now is that there is expansion of the radiation protection requirements. So I do structural work as well as peripheral vascular. I have an anesthesiologist, I have a fellow at the head of the bed doing echo with an attending and an echo tech, and they're not the Rube Goldberg stuff we do up there to try to keep them protected is inadequate.
Right.
So I think that the need for radiation protection in terms of the people in the room is growing exponentially. Working from both sides of the table on TVARs and EVARs and things like that, it's a big deal.
Yeah, it's a big deal. I think part of the reason that it's not thought about on a regular basis is because, or ignored, is because the consequences of getting radiation are delayed, and you don't think about it until you have the cancer or somebody around you gets the cancer or leukemia. You know, one of my colleagues, Chip Gold, got leukemia. I'm 100% sure it was due to radiation, and people know about Ted Dietrich and his brain tumor. I mean, you don't think about it until it happens to you. And the same thing is true for the orthopedic issues,
Correct.
which are much more prevalent. I've been amazed at talking to colleagues who've been in practice for 20, 25 years of mine, how many of them, it's almost 50%, have had a back operation. One after the other after the other.
And it limits careers.
It limits careers. I tell people about the fact I've had 4 surgical procedures, 4 operations on my back in the past 4 years. And they say, oh yeah, I had my neck operated on, I had my back operated. It's unbelievable. What, really, you too? It's actually, it's not talked about very much because we don't talk about our own personal health, but it's a hugely prevalent. So we're here with Salus Scientific, which is committed to this space in a big way with some really innovative and novel technologies. I use their G-Lift lead. I actually could not practice without it. If I'm wearing traditional lead, I'm done in a half hour. I can wear that Salus Scientific G-Lift for 8 hours, 10 hours, doing complex peripheral cases and BPAs and complex coronary cases. And at the end of the day, I'm still pretty fresh, which is actually remarkable. For me, it's been a game changer. Trying to get other people to understand that. And when they try it, they're kind of blown away by it. And it's a pretty simple thing. But there's much better things that we can do. And so I want to talk a little bit about that. Gloria, I understand that you have a G-Lift as well. Maybe you could talk about what your experience has been with this new product.
Yeah, I agree with Kenny about the ergonomics of the G-Lift. It really takes away the heavy lift on the shoulders, literally, and it does make you happier. I think during the case, I think you can last longer depending on the complexity. But in addition to that, one of the major gaps in lead design, lead apron design, is the coverage for women, for example. Starting with pregnant women, having the appropriate design for women that will have children, and the G-Lift can be the lead itself can be tailored for that. And the second thing that I noticed is also proper coverage in the axilla for the breast, because we know obviously the radiation is a carcinogenic reason for breast cancer. So covering that area is really helpful. So I believe that there are many different reasons for why you should consider having that in your practice for yourself.
Yeah, just to make that point, I know there's an article out somewhere about the orthopedic folks. And are you aware of that article?
I am aware, but I don't know the details, but essentially it's essentially increased incidence of cancer.
Apparently a huge incidence of cancer, breast cancer, of one particular breast in orthopedic females who are right breast because of the angle that they have to use to do their knee replacements and so on, and the angle that the X-ray beam is that it focuses right on that spot. So the great thing about Salus is they're accommodating for that. They're thinking about these things in advance to try to protect us.
Absolutely.
Yeah, I think I've used a G-Lift too. I have one, and I like it. Unfortunately, it doesn't cover anybody else in the lab. So the rest of the people are suffering silently while I'm like floating on air. And while I love the G-Lift, and I think it would be great to get it onto everybody, I think the bigger attraction or the bigger goal should be to try to minimize the amount of lead that we have to wear as a team.
Right.
I think the G-Lift is certainly a step toward that in terms of some of the orthopedic and potentially oncologic things. But what we're really talking about here is radiation scatter protection. And, Kenny, I know you've been committed to this, heart and soul and body, for the last several years. And I don't know, you probably have some kind of, tenets that you think need to be followed when talking generically about, what a radiation scatter protection qualities should be.
Well, are we doing well enough with what we have? And my answer to that would be, and I think you guys as well, would be no.
Right.
We're all forced to wear individual lead. We're not protecting ourselves ideally. We've talked about the fact that we don't adjust things properly in the lab. It falls to the wayside. We don't think about it. So quite frankly, there needs to be an automatic sort of passive, it's always there, doing the work for us without us even knowing that it's there.
Right.
And that's not where we are now. There are other systems that have tried to get there. Quite frankly, I'm not going to speak disparagingly about any other system because I think they all are trying to do the same thing. We're all working to the same goal, which is to try to protect everybody in the room and to minimize the amount of lead that or aprons that we have to wear.
Yeah.
We should define that a little bit. I mean, there's a lot of conversation about, getting rid of all of our lead. But honestly, I don't think that's the goal. The goal of getting rid of lead means you're never gonna have an emergency. Getting rid of the lead means you'll never have an exposure to radiation. That's just not realistic. Right. And quite honestly, I don't think any system that is workable and flexible enough to, have multiple access points and multiple, positions around the table is going to really protect everybody at all times. So I don't think that's the goal. The goal is, I think, to get into what is probably a quarter of the weight of the lead that we currently use. Right now we use 0.5, and going to 0.125, I think, is the goal. And we've all tried those on. It's like a rain jacket. It's like nothing. And so it's a meaningful difference in how much weight we're carrying, but it has to be married to effective scatter protection.
Absolutely.
Yeah.
I think that's the point. Well, the combination of the advanced ERPD and wearing very light lead.
Right.
In some cases, you might be able to get away without wearing any lead. Depends upon the angles and so on and what the procedure
complexity of the procedure, whatever.
Complexity and so on.
I think we paid very less. We did have attention to radiation knowledge, but we don't know and we don't utilize the collimator, the things that we already have embedded in the machine. And now the least of what we think is the scatter radiation. I think this is something that we can quantify and reduce significantly for everybody in the room. And I believe that knowledge is power. So if you measure it and then you notice how much less radiation you can achieve with the systems that protect the machine itself to the other way around towards the team in the room, I think that's something very valuable and it goes a long way.
Yeah. No, I think quite frankly, that's why I love this company. I love Salus because they're actually thinking about the wraparound protection, 360. Right. Like what works for you in your lab, what works for you as an individual. Is it wearing light lead with the Aero Shield? Is it wearing no lead when you're doing a certain less complex procedure where everything's positioned properly? Are we protecting the radiologist, of course?
Yes.
The anesthesiologist, are we protecting the echocardiographer, which is a huge issue, and a lot of these other systems don't actually address that. The incredible thing about this system, and we're moving into the discussion a little bit about Aero Shield, is the ability to customize it, to adjust it, to change, even on the fly.
To deploy specific segments,
Exactly.
Yeah.
And also to replace parts pretty easily that are non-functional if something happens. And I think this company has it right. They have we're going to service everybody. We're going to take care of your lab. We're going to make it right for you. If make your G-Lift fit the right way, customize it. We'll make your Aero Shield system fit the right way to your needs. And your needs are certainly going to be different than my needs, Bill's needs. And Bill's do a lot of structural stuff. I don't.
Yeah. No, I think, there are now structural procedures which are being done for the jugular.
Right.
So as an operator, I have like no protection up there. And
Yeah.
what needs to happen is there needs to be a flexibility in all of these access points.
Yeah.
And I think this particular system allows for that.
Yeah, I mean,
Yeah.
it's versatile. It's
Yeah.
versatile. You can use it for peripheral, coronary, and by the way, you still have access to the patient, direct
Right.
access
Yeah,
all the time.
exactly.
Which I think not all these systems allow that. That's obviously got to be, for me, it's a premise. You know, we did this survey. I don't know if you guys were part of that, but one of my fellows, Adam Johnson, spearheaded this survey,
Delphi consensus.
process.
Yeah, we were involved with that.
Yeah, and it was really cool. It was like asking, what is the most important thing to you? And invariably, it was having access to the patient.
Right.
It was almost number one, so you can take care of the patient. Number two is that it had to fit with the workflow. High up on the list was obviously protecting every individual person and preventing the ergonomic trauma
Yes.
that leads to back surgery and 50% of interventionalists who are in practice for more than 20 years.
Yeah, there's definitely a need to look at this scatter radiation at the room because we're doing more complex procedures. Even though we're advancing our technology, there's a lot happening at the same time in the patient and for the team doing the cases with us. So definitely something that will be very important in the future.
Agree.
All right, so are there any let's talk about this for a second, a little bit more about workflow. Are there any kind of non-negotiables for you? What is a showstopper? What would not allow you to put a system in your lab?
I think if the system's not fluid with the workflow.
Yeah.
So, you have to be able to get a patient on and off the table.
Right.
Staff has to be able to clean and drape the patient. They have to be able to establish the radiation protection system. All those things are going to be critical to, maintaining acceptance of any system. Like we all want radiation protection, yes, but the pain to gain ratio has to be acceptable at some level, right? And I don't think it's realistic to think there's not going to be any inconvenience. There's going to be some
Yes.
because we're establishing another barrier. That's okay, but it has to be reasonably flexible enough that you can do it without a lot of lost time or a lot of.
So it can't take 10 minutes in between cases
Correct.
to
No.
Correct.
undrape, redrape an ERPD.
Yeah, it has to be cleanable. It has to be.
Yes.
It has to, all
Like
that stuff.
infectious
has to be
disease
exactly
compatible.
Right.
But I also think even when I switched from femoral to transradial approach, it was taking 10 minutes, 30 minutes, 10 minutes, whatever. There is a learning curve too for this. But
course.
facilitating that, it's really important for implementation. And I would add the data. If the staff knows how much less radiation they can have in the room, I think they're all will put their heads together. Let's just get it done.
I think our staff will be on
Totally.
fire.
Exactly.
I mean, the other thing we didn't talk about is cost. I mean, it has to be cost effective, not just in terms of keeping the room moving, but also has to be cost effective. The device itself can't cost too much, and that's another benefit I think of Salus's AeroShield system, and even the G-Lift and the ongoing monitoring.
Yeah.
It's not $30,000, $50,000 for ray safety.
Yeah, I
to be
mean,
honest.
we all come from big systems. I have 20 labs in my system, and that's not including radiology.
Right.
And just cardiology labs. And so I can't spend,
Yeah, it's
I can't
it
spend an arm
becomes
and a leg for each one of them. And I want to spend the money. I don't,
Yeah.
So
wanna
let's
commit.
let's just summarize here. If each of you had to sort of summarize what you're looking for, what separates sort of good enough protection to best in class, what would you be aiming for, Gloria?
Yeah, no, definitely. I think, as I said, as the procedures get more complex, this is when it makes a difference to having those systems, right? We are all in academic, large hospital systems, and that's what we're going to have. So for me, for my future, is to have a equipment that is ergonomic, that is protective, but also that allows me to perform my procedures the best for the patient, the best for the technique. So that's what I'm aiming for, and that's what I think we can achieve with some of the equipment that we're discussing here.
It's well said. I think the other thing I would add to that is that, many of us use extreme angulation for our procedures.
Yes.
And many of the existing devices don't really allow for that very easily. You have to kind of move things around a little bit. So the flexibility to move the image intensifier into pretty much any position is going to be critically important without a lot of gymnastics.
Yes.
I mean, I saw Bill Dixon had one of the Aero Shields set up in his lab today and used it and was commenting that you don't even know it's there. And that's what
That's
you
good.
want. You want something that actually does its job, protects everybody in the room, reduces radiation by 95%, so you can wear light lead or no lead, and you don't even know it's there. That's the ideal. To me, that's the holy grail, and is cost effective and is widely disseminatable. And in fact, you mentioned that we're in academic centers, but frankly, this system is probably the only one I've seen that can actually easily be used in OBLs, in ASCs.
Yep.
You really don't need to have a fixed C-arm. It can be used with mobile C-arms and so on. And that's actually huge because there's a huge number of OBLs and ASCs out there, and those patients and those healthcare workers need the same kind of protection for their backs and their
Yes.
It's a great point.
scatter radiation. So, all right. Well, thank you everybody for listening. Appreciate your attention, and thanks to my colleagues, Gloria and Bill.
Thanks,
Great
Kenny.
discussion.
Yeah.
Great discussion. Thank you.